Welcome, everyone. We'll get started in a few minutes. In the meantime, please feel free to introduce yourself in the chat, your name, your organization, your title, and just for fun, sharing your favorite national or state park in California. So my name is Shannon Arvizu. I'm the director of the County's Rise project at UC Berkeley, and of course, Yosemite. So I took that one. So see if you can find one of your own to add to our chat. Pinnacles. That's a good one, Jason. When was the last time you were there?
I think I was just last year actually. It's the first time I've been in many years. So, but yeah, I just think it's such a cool and unique park.
Mm-hmm. Agreed. Yeah, Point Ray is gorgeous. Can get quite windy, but it's definitely gorgeous. Sequoia, Kings Canyon. Another vote for Sequoia here. Nice. And feel free to toot your own county's park. Nice. Avenue of the Giants, where Bigfoot lives. I love that. Of course, Redwood National Park. Those trees are so striking. Torrey Pines Natural Reserve. Oh yeah, Inyo National Forest, good one. Another vote for Yosemite. Welcome those who are just joining. Please feel free to introduce yourself in the chat, name, org, title, and favorite national or state park in California. And we'll get started in probably one more minute. Ooh, Channel Islands. Nice one. Don't tell people about the Yuba.
I like that. I like that one.
It's our little secret. Okay. All right. Well, please keep your introductions coming. It's nice to know who's on the call with us. I'm going to get us started. So, welcome to today's webinar, Navigating the MCO Tax and Proposition 35, Implications for California Counties. And this is the second webinar of our Counties Rise Project webinar series. And we'd love to pass it on over to Jolie Onodera from CSAC.
Great. Thank you so much, Doctor. And I just want to welcome everyone to today's webinar. So excited to see so many county folks in the chat with your favorite parks. I have too many, so I don't know that I actually have just one specific one. But anyway, yes, Jolie Onodera. I'm the Senior Legislative Advocate here at CSAC over the Health and Behavioral Health portfolio. And as we all know so well, there's just so much going on in this space at the federal, state, and of course local level. So just really excited about this presentation and conversation today, and just want to thank everyone again, and especially thank Dr. Avizu and her incredible team that we've really enjoyed working with. In particular, my colleague Jessica Sinkis has been working very closely with Dr. and her team on the County's Rise project. And with that, I'd like to just turn it over to Dr.
Thank you so much. And also just a quick introduction to our County's Rise project before we get into our main event today. This is a new initiative at the Goldman School of Public Policy at UC Berkeley. Counties Rise is an acronym. It's a research initiative in service essentials. And we designed this as an agile policy research product to help counties monitor and respond to federal and state changes, particularly as they relate to Medi-Cal. My name is Dr. Shannon Arvizu. I'm a sociologist. I was also the former senior advisor to the White House chief data scientist before my role here at UC Berkeley. And a little bit about the goals of our project here. First goal is to capture the policy landscape to understand impacts to county level populations and health systems. And with our snapshots, I'm going to share a little bit about our Medi-Cal policy snapshots. We wanted to convey this information in very plain language, so that way all county level stakeholders, whether you're, on the board or maybe even, your county executive, maybe you're not a healthcare policy expert, but you want to understand on a more local level what the changes are. These snapshots are designed to serve that need. And we're building these snapshots with county stakeholders. So it's really important for these data products to reflect the realities of counties themselves. So our main deliverable, as I mentioned, are these Medi-Cal policy snapshots. We produce them now for about 15 counties, and each snapshot has a current state of Medi-Cal, how it's managed in the county, 2025 policy changes. Actually, Jason's team at LAO helped us um, draft that. And then we have more information on population impacts, health system impacts, and economic impacts. So, as I mentioned, it's a 12-week project. We are in the home stretch here. And so, to kick us off in our second webinar today, Jason Constantoros is going to be talking about the MCO tax. And just a little bit of background about Jason. He is the principal fiscal and policy analyst at the Legislative Analyst Office for the state of California. And he covers a variety of health policy and fiscal issues, including Medi-Cal managed care. We're very grateful to have Jason here today. And with that, I will stop sharing my screen and let Jason take it away. Oh, before Jason starts, I do want to share that if you have questions as they relate to Jason's presentation, please feel free to write them in the chat or in the Q&A. Actually, the Q&A section is a great place for that. And I will be your chat concierge. So at the end of the presentation, I'll be able to field those questions directly to Jason. So with that, please, Jason, take it away.
Great. And is my screen properly shared? Perfect. Great. Well, thank you, Dr. Revizu. It's nice to be here. So I was asked today to talk a little bit about the MCO tax and Proposition 35 and some of the changes that sort of are upcoming with the MCO tax. One thing I did want to note is, we focus a lot up here in Sacramento on sort of statewide issues, and I'd be really interested to hear, during the presentation or afterwards, kind of some of the concerns or questions that you may have at the county level about the MCO tax and kind of the impacts that you're sort of anticipating or wondering about. I think that would be really helpful to hear. So, but with that, there we go. Got the slides to work there. So before I dive into the presentation, just wanted to make sure folks kind of were aware of the LAO and who we are. I'm not sure of everyone's level of awareness. But if you are familiar with the Congressional Budget Office in DC, we are basically California's version of that. We advise the California legislature on budget and policy issues, and we're nonpartisan. And we cover all sorts of areas in the state budget, including health issues, which is what I work on. And as part of that, we have several activities. We analyze budget proposals, we provide technical assistance, we forecast the state budget, we produce reports throughout the year on budget and policy matters. And then we also estimate the fiscal impacts of measures that are on the statewide ballot. So I think you all sort of voluntarily chose to be here, so I don't need to explain too much about why this topic, just to kind of get us on the same page here. The MCO tax has been a hot topic in recent years. It's because it's a major way the state pays for Medi-Cal, which is the state's Medicaid program covering healthcare services for low-income people. And this tax has changed very dramatically in recent years. It's increased, And then voters approved a new ballot measure, which we'll talk about it. And then there are some upcoming federal changes that also could require significant changes to the MCO tax moving forward. So with that, I'm going to talk about how the MCO tax and Proposition 35 work, and then I'll talk about some of the recent federal policy changes and how those will impact the MCO tax. So just moving on to the first part. So, what is the MCO tax? And this is a topic that can seem really complicated and difficult to understand. But at its very basic level, it's actually very simple. The MCO tax is a tax on health plans. So if you think of Kaiser or Blue Cross or Blue Shield or LA Care Health Plan, these are health plans. It's how most people access health insurance. MCO is just kind of a techie way to describe what a health plan is. And it's a tax that the plans pay. And currently, it's changed over time, but the way it currently works is it's a tax on the number of people that each plan enrolls each month. So as health plan enrollment increases, the health plan's tax burden increases. And the tax is set aside. It's set aside and used specifically to support the Medi-Cal program. So it's designated for a particular purpose. And it currently raises about $7.5 billion annually to the state. Where things get a little more complicated is that there are actually two different sort of tax rates within the MCO tax. There's a tax rate on Medi-Cal enrollment and a tax rate on commercial enrollment. Now, commercial enrollment probably is the most intuitive. If you think about people who have insurance through their employer or who buy insurance on their own, this is sort of commercial enrollment. People enroll in it, and then there's a premium, and either the person pays the premium or the employer pays the premium, or it's split between the employer and the person. Medi-Cal might be a little less intuitive, but to understand that, the way Medi-Cal works primarily is by contracting with health plans and enrolling Medi-Cal beneficiaries in a health plan. And then the health plan oversees the beneficiary's care. And then there's what you might think of as a premium, but that's paid by the Medi-Cal program instead of the beneficiary. And so because of that, many health plans also have people on Medi-Cal. And in fact, if you look at the split of enrollment, it's about 50-50 Medi-Cal and commercial enrollment. And what's important here is that the tax rate on Medi-Cal enrollment is much higher than the tax rate on commercial enrollment. It's more than 100 times higher. And so even though enrollment's about 50-50 Medi-Cal and commercial, over 99% of the revenue comes from the tax on Medi-Cal enrollment. Now you might wonder, okay, why am I making such a big deal about there's a tax on Medi-Cal and a tax on commercial enrollment? Why am I making such a big deal about that? Well, that's because even though this is a tax on health plans, who ultimately bears the burden of the tax really differs depending on what kind of enrollment's being taxed. And this is probably the most complicated and unintuitive part of the MCO tax. But to understand it, I think it's helpful to think about, what happens when you tax a health plan. When you tax a health plan, it will try to either partially or fully recover the cost of that tax by raising premiums on consumers, right? And so shifting the cost. Well, for Medi-Cal enrollees, remember that the Medi-Cal program pays the premium, not the beneficiary. And Medi-Cal pays that premium in part using federal funds. And so the effect of this really is that the tax on Medi-Cal enrollment isn't really borne by the health plan. It's really paid by the federal government. And so the MCO tax really is a way that the state draws down more federal funding. That's really where the source of the revenue ultimately comes from. Like I said, there is a tax on commercial enrollment, but it's much smaller. And a tax that generates about $7.5 billion annually to the state. About the low tens of millions comes from the tax on commercial enrollment. And if, plans likely, try to recover at least some of that by increasing premiums on consumers of private health insurance, but it just doesn't translate to a very meaningful impact. It's so small. So really, this is a tax at the moment that's really coming from federal funds. That's really where we're getting the money from. So the MCO tax has existed for like more than a decade. And the way it worked historically is the legislature would approve the tax for a limited time and then renew it again every few years. And each time it renewed it changed the structure of the tax a little bit. And to some extent also maybe changed how it's used in Medi-Cal a little bit. Well, in 2024, voters passed Proposition 35, which effectively took the decisions around the MCO tax mostly out of the legislature's hands and sort of made it permanent and automatic. And it does this in two ways. First, it makes the tax permanent in state law. And so the tax and largely its existing structure are kind of permanent without requiring legislative approval. And then also importantly, the measure also limits the size of the tax on commercial enrollment. And it does this to presumably to protect private health insurance consumers from high costs from the tax. The second way second element of Proposition 35 is it also creates rules on how to spend the MCO tax funds. The funds from the MCO tax still largely support Medi-Cal. There's some funds that are set aside for other health programs too, but largely it's still to support Medi-Cal. It does this in two different ways though. Some of the funds support the existing Medi-Cal program. And when the state uses funds this way, it means that the state doesn't have to cover these costs from other sources. So it really creates state savings. The second kind of broad use of funds is to support augmentations in Medi-Cal and also some other health programs. That increases spending on Medi-Cal rather than saving the state money. And then there are kind of different rules in the short term and the long term. Now, the rules get kind of complicated. I haven't really figured out an easy way to comprehensively and simply show the rules, but I do have a couple of figures just to explain how the rules work kind of generally. So this graph here shows largely what the rules are like in the short term. So in the first 2 years in 2025 and 2026, and then in the long term beginning in 2027. And that dark blue part of the bars are, represent augmentations and spending increases. And the lighter blue represents state savings. And there's kind of two key takeaways here from the chart. One is that in the short term, there's sort of specified dollar amounts that go to each purpose. Whereas in the long run, there's really more proportionate amounts. And it's proportionate because in the long term, we don't know exactly what the MCO tax would look like. So making them proportionate allows the state to ratchet up amounts up or downward depending on the size of the tax in the future. And then the second thing I want to emphasize is you'll see that that bluer bar for augmentations is bigger in the long term. And generally that's because a greater share of money in the long term is for augmentations. It does depend a bit on the size of the MCO tax, so there's a bit of an asterisk there. But generally, assuming the tax is about the same size as it is today, there would be sort of more funding for augmentations in the long term. And then another thing about the rules is, I said they're augmentations. Well, what are these augmentations? Well, for the most part, they're provider rate increases in Medi-Cal, but then also some other health program issues, mostly focused on workforce. And you can see that there is a lot of crossover across the years, but there are some cases where some services get increases in the long term, but not the short term. Dental is a good example of that. Emergency air is another. So there are some differences in who gets funding in the short term versus the long term. And then the state doesn't have yet a long-term spending plan for Proposition 35 that hopefully will become somewhat apparent as we go through the presentation about why that is. But the state did recently come up with a short-term spending plan for those first 2 years in 25 and 26 about how the augmentations would be sort of structured and spent. And that's what this table is showing here. There's a lot here, but the top half of the table shows how the funds are allocated by service. And these amounts are actually specified in the measure. So these are required amounts. But the bottom half of the table shows how they sort of intend to allocate the funds by service area. And that's sort of new. And so what you can see here is they're planning to support a number of different things, including ongoing provider rate increases, some one-time rate increases or limited term rate increases, also various workforce initiatives, housing subsidies. You may have heard, if you've been following the MCO tax, that the state, some of these augmentations are actually helping to save the state money. And that's really that line that says underlying base managed care rate growth. And that's kind of a techie terminology, but what all that's really saying is that the administration estimates that in recent years, Medi-Cal costs have grown. And so they'd like to count that cost growth as an augmentation, but it also saves the state money because the state would have otherwise paid for that growth. And so that's what that line is showing. Those are sort of additional savings by counting cost growth as an augmentation. And then the kind of final important piece, and this will kind of set up the discussion later, is that the MCO tax also requires federal approval. And this is unique relative to most other taxes in the state. Usually the state doesn't have to get federal approval for its taxes. But it needs to get approval here, and that's because of the way the MCO tax works. And I should preface to say that the MCO tax is actually a part of a broader group of taxes called, healthcare related taxes, or the short terminology you'll hear often is provider taxes. And these are taxes on healthcare services that states use to support their Medicaid programs. And almost every state has at least one. Most states have more than one. California actually has 4 provider taxes, so the MCO tax is just one. And the federal government regulates how states can use these taxes. And it does this because states are using these taxes to support their Medicaid programs, and they're doing it in a way that results in higher costs to the federal government. Now, the rules are pretty technical, and we just don't have time to get into all of them. But if you think about kind of what the rules are trying to do, they're really trying to limit the cost to the federal government. They do this in part by trying to limit states' ability to taxing Medi-Cal services too disproportionately, and also by limiting the overall size of taxes. So that's kind of what the rules do. They try to do this with using more mathematical tests, but that's kind of the gist of it. So the California's current MCO tax has federal approval through the end of 2026. That's why Proposition 35 has one set of rules in 25 and 26, and then a second set of rules beginning in 2027, because in 2027, that's when the sort of new tax would start. Now, even though we got approval for this version of the tax through 2026, the federal government also wrote a supplemental letter that raised concerns about our tax. Those concerns were basically that our tax meet the technical mathematical rules, but despite meeting those mathematical rules, our tax is still generating 99% of its revenue from Medi-Cal enrollment, and therefore really from federal funds. And so because of that, the federal government sort of argued that it really didn't meet the spirit of what the rules were trying to get at. And the federal government even went so far to call our MCO tax a bit of a loophole. And so in its supplemental letter, it signaled that it intended to change the rules in the future to better align with the overarching goal of not having the tax be too disproportionate on Medi-Cal. So that kind of brings us into the sort of recent federal policy changes that have happened. And when I say recent federal policy changes, what are we talking about? Well, there's actually kind of 2 things at play here. And the first actually happened in May 2025, and that's in May, federal administrators proposed a new rule around provider taxes. And so that's kind of the new rule that they had been signaling for some time. The rule is still sort of proposed. It hasn't been finalized yet. And then the second thing that happened in July is Congress enacted the One Big Beautiful Bill Act. That's probably something everyone here has been tracking, at least to some level. And that, as many of you know, makes a number of policy changes to Medicaid. And some of those affect provider taxes. And there's some crossover between the proposed rule and the One Big Beautiful Bill Act. So we'll try to break that down a little bit. So among these changes, among these sort of federal actions, there really are 2 key changes that are important for the MCO tax. The first one is really an effort by the federal government to limit states' ability to charge taxes that are overly disproportionate on Medicaid services. And this is both in the proposed rule, and then the One Big Beautiful Bill Act basically codified certain parts of that proposed rule. And if you read the language itself, it's kind of technical and hard to follow. But the important thing for California is it basically prohibits states from charging higher tax rates on Medicaid than non-Medicaid services. In terms of timing of when this would start, it's actually, there's a fair amount of uncertainty. When HHS proposed its rule, it said that the rule would become effective once it's finalized. They were sort of speculating maybe in early 2026. And then they also said they might give some states, but probably maybe not California, but some states more time to sort of adjust. The One Big Beautiful Bill Act actually made the new policy change effective in July of this year. And then it gave HHS up to 3 years to implement the requirements. So there's some uncertainty about when this kind of would come into effect. It could come into effect as kind of retroactively in July. That's a possibility, or it could come into effect later. It really depends how HHS chooses to sort of implement the new law, and also how they finalize their rules. And then the second change to provider taxes that's significant is a reduction in the revenue limit. So currently there are rules that generally limit the size of provider taxes. And beginning in 2028, the One Big Beautiful Bill Act reduces this limit gradually over time until it's slightly less than half of what it was before. And this is relevant because the MCO tax is currently at the current limit, and so over time it would not be able to. It would have to go down to sort of meet the new limit. Also importantly, this reduction in this required reduction in the revenue limit is only for states that implemented the optional Medicaid expansion to childless adults. That was part of the Affordable Care Act. And the important thing there is California is one of those states. So this provision affects California. So how do those changes actually affect the MCO tax? Well, of those two that I mentioned, the first one affecting how disproportionate the tax is, that's really the one that we've been tracking as probably the most significant. And that's because, as I said earlier, Medi-Cal, the MCO tax, is very disproportionate on Medi-Cal services. It charges more than 100 times the rate on Medi-Cal enrollment relative to the commercial enrollment. Now, also importantly, remember that Proposition 35 limits the size of the tax on commercial enrollment and basically limits it to the low tens of millions of dollars each year in revenue. That's about how much revenue we could generate from that tax. So, if you think about it, we have a federal rule that's saying we can't charge Medi-Cal, we can't charge a higher tax rate on Medi-Cal services than on non-Medi-Cal services. And then we have a measure that says the non-Medi-Cal tax rate has to be in the tens of millions of dollars. So if you put that together, it sort of suggests that to comply, California would really need to reduce the size of the tax on Medi-Cal enrollment without really being able to offset the decrease by increasing the tax on commercial enrollment. And so in that case, we'd be looking at an MCO tax instead of that generates billions of dollars, would generate more in the tens of millions of dollars. An order of magnitude that would make the MCO tax fairly inconsequential fiscally compared to where it's at now. I did want to note that Proposition 35 does allow for amendments from the legislature with a 3/4 vote in each house. Those changes do have to be consistent with and for the purposes of the measure. If the legislature were to pursue something like that, it would also have to grapple with, potentially some of the difference, sort of a different policy framework. Right now, the policy around the MCO tax has been to have a very large tax on Medi-Cal enrollment and a very small tax on commercial enrollment, and really to draw down as much federal funding as possible. If the legislature were to increase the tax on commercial enrollment, that would be a change in policy. That would mean that health plans and private health insurance consumers would bear more of the cost to help support Medi-Cal. And then, as I noted earlier, the timing of that change is really uncertain. It's uncertain if it would be retroactive to July of this year or it would start later. And so that's also something where policymakers are sort of keeping an eye on. So if there is a smaller MCO tax, and it seems like that's probably where we're heading, what does that sort of mean for providers and for the state? So for providers, that would just mean very small augmentations. There still would be an MCO tax, but instead of having billions of dollars for augmentations, it would be in the tens of millions. And those tens of millions would be spread out across many different areas of augmentation. Some would go for physician rates and some for hospital rates. And then within those areas, then providers would have access to some of those amounts. So you'd be looking at, fiscally probably not a very significant amounts of money going to providers relative to what it would be if the tax were still very large. Generally, this probably doesn't look like a decrease for most providers. My sense is it would be more of an opportunity loss rather than a direct funding cut. But it could be the case that many providers had been sort of planning and expecting to get augmentations, and now those augmentations won't be coming into fruition. So that could have some effect on providers' operations. Another thing you likely will start seeing, and that's already kind of part of the existing spending plan, is a greater focus on limited term spending for the augmentations. And that's because these augmentations, can't be sustained at billions of dollars each year, kind of permanently. So you'll likely will see a greater emphasis on limited term supplemental rate increases or limited term workforce initiatives, ways to sort of mitigate sort of financial exposure to the state to have to sustain anything from other sources if the MCO tax is smaller in the future. And then in terms of the state, what you'll sort of see here is potentially direct costs to the state. In the short term, the MCO tax is providing billions of dollars in savings, direct savings to the state. So if there's any impact to those funding levels, then the state would either have to backfill it from other sources or find programmatic reductions in Medi-Cal. In the long term, there also would be a cost, although the long term cost there is probably more limited. And to understand that, when the state adopts a budget each year, it also adopts kind of a multi-year assumptions around what spending might be over the multi-year. And in those multi-year assumptions, although all of the assumptions aren't always super visible, but it's our understanding that it makes assumptions around the MCO tax being smaller, and then also more of the having fewer savings because more of the funds would be used for augmentations instead of savings. And that's pursuant to Proposition 35's rules. So because of that, relative to that assumed baseline in the longer term, while there would be fewer state savings and so therefore a higher cost, it probably wouldn't be it might not be in the billions of dollars. It might be a smaller amount. That said, there could be indirect cost pressure to the extent that providers were expecting larger augmentations that could put pressure on the state to find other ways to sustain them from other sources, such as from the general fund on an ongoing basis. The challenge you're going to see there, though, is that the state budget is projected to have an ongoing budget deficit. As many of you probably know, in this year's budget, the state took a number of actions to reduce ongoing Medi-Cal spending to try to grapple with that deficit. Nonetheless, there still is a projected deficit in the future. So the state's working already with a pretty constrained budget. And so its ability to sustain augmentations on an ongoing basis might be pretty limited. That's kind of my overview. I did want to leave ample time for questions or other comments. So with that, we can turn to the next step.
Thank you so much, Jason. Really appreciate that explainer. I mean, I really appreciate the first part of your presentation where you just give us a good lay of the land in as much plain language terms as you can, because I know this is a complicated policy landscape, if you will. I was, thinking about the augmentations, and could you share that slide again where you have the list of augmentations? I think it was probably, yeah, it's a little bit lower. And so my question, I was thinking about even just the term augmentations is a little wonky. And I was thinking about how the MCO tax, in some ways, as I looked at that list of augmentations, seems like it's playing a key role in funding system level improvements. And so I was wondering if that is the right interpretation, in addition to savings for the state. Another way of thinking about those augmentations are system level improvements that might not otherwise be funded.
Yeah, so I know augmentations is a wonky term. You can think of it as a spending increase, and how they would look would depend a little bit on how the state implements them and structures them. Generally, I think most stakeholders have been assuming that these would be and generally that's how they are planning to use them, for provider rate increases.
Mm.
So this would, for example, where it says primary care or specialty care.
Oh, by the way, we can't see the slide.
Oh, you can't?
No, maybe you could like share I think it might be just frozen on the title slide. Maybe stop sharing and share again. And then we also have a couple of questions that have come into the Q&A. So please feel free to yes, now we see it. Thank you so much. Okay.
Okay, sorry about that.
Uh-huh.
So where it says primary care or specialty care, those would be physician rates. And to some extent, not, some other, it's complicated, but generally physician rates, rate increases, or hospital rate increases. There are some other things like, supporting workforce programs. There's money for a program that gives out money to physician residency programs, and there's money
Mhm.
for to expand the number of providers that serve Medi-Cal.
Mhm.
So they really are quite varied, but a lot of them are, at least I think in concept, are focused on provider rate increases. And there's been interest in increasing provider rates because there's kind of a longstanding concern that around rate adequacy in Medi-Cal. Rate
Mhm.
adequacy is kind of hard to definitively study. In part, as I said, the way we primarily deliver services is by contracting with health plans. Health plans really set their own provider rates, and a lot of the data there are sort of trade secrets. So we don't have great information on rate adequacy in the managed care system, but there's been a long-standing concern generally about rate adequacy. And so and the concern there is if rates aren't sort of high enough, may not have a sufficient number of providers in the network to serve Medi-Cal patients. Providers
Mhm.
might focus more on people with private insurance where the pay is better. And so by increasing provider rates, the idea would be to sort of improve access to care for Medi-Cal beneficiaries. And there's some evidence that rate increases tend to be associated with some improvements in access, although they can be mixed evidence in some cases.
Noted.
So that's kind of generally how I would think about those augmentations. Again, in most cases, these aren't rate increases that have happened yet. So they're rate increases that would have happened and now aren't going to happen because of the tax won't be, or they'll happen, but they won't be, instead of being quite significant, they'll be quite insignificant because of the size of the tax.
Got it. Okay, thank you for that. So we have a few questions coming in. The first one is OBA also limits reimbursements above and beyond the Medicare rates. Will
Yep.
this impact the state's ability to support augmented payments?
Yes, so that is a third provision. It doesn't directly affect provider taxes, but there is an effect. So like I said, the state has four provider taxes. The largest one is actually not the MCO tax. It's a fee on private hospitals called the Hospital Quality Assurance Fee. And that does support rate increases to hospitals. And also public hospitals get additional federal funds also through a separate program. And my understanding is their payments in some cases are greater than the Medicare rate. There isn't great information, but that's my understanding. And so that would result in lower payments. In particular, the state in 2025 planned to notably increase payments to hospitals, including by really increasing the fee on private hospitals to support that. So there's some uncertainty about whether that would get approved. And then also, if there are declines, those declines also happen gradually over time. You have to kind of reduce payments by 10% each year until you get there. So the decreases would be gradual, but there would be an impact. My understanding primarily on sort of hospitals.
Noted. So our second question from the group is, can you explain what key things would be different if Prop 35 hadn't passed? In other words, what the legislature is looking at now in regards to reductions from MCO tax revenue because of federal policy changes, options that are restricted solely because of Proposition 35.
Yeah, those are well. So just to sharpen that question a bit, you're really asking two things. You're asking, um, what would have happened if Proposition 35 hadn't passed, and what would have happened if we didn't have the federal policy changes? Because
Mm-hmm.
you could imagine you can imagine a scenario where there would have been no Proposition 35 and no federal policy changes.
Mm-hmm.
But if you read our analysis on Proposition 35 in the voter guide, you probably would remember that we um, kind of pled the fifth on that. It's hard to really know what would happen absent Prop 35 because it's hard to know what decisions the legislature would have made in the future. So that's really hard to sort of speculate on. Had there been no federal policy changes, I guess to simplify the question, let's assume that there's Proposition 35, but no federal policy changes, then presumably what you'd have is still a very large MCO tax that could support much larger augmentations. But in the absence of Proposition 35, It's sort of hard, it's hard to really speculate about what decisions the legislature would have made.
So another question is, or a statement is, I'm concerned about the impacts of the reconciliation package to provider rate increases, and specifically how that impacts rural hospitals with high public payer mixes. Is there public information available to quantify impacts for specific hospitals?
Yeah, we've been reviewing some evidence that we've seen. It's that I would probably say there's not at the moment great. I think folks are still getting their arms around the potential fiscal effects. I'm not
Mhm.
familiar with very precise estimates, particularly for rural hospitals. There is a program in the One Big Beautiful Bill Act that's supposed to increase funding for rural hospitals, and states can apply for it. But there's a lot of uncertainty about, who would get the funds and how that would look and what the impact would be. So yeah, I don't think there's great information at the moment, but yeah, like I said, you could imagine there being declines in over time to hospital payments as a result of the new Medicare cap. And so that would be something to keep an eye on.
Another question, with the HR1, Big Beautiful Bill, potential rule changes or other efforts create volatility in the structure that would be seriously detrimental to the state county expense.
The question was, does this create more volatility for counties?
Yes, yeah.
Well, I'd be interested to hear from county folks, actually. I'd be interested to hear your perspectives on that. In terms of the MCO tax, you can imagine the MCO tax, some of this having some direct impact on counties, in particular for hospital services, for counties that have hospitals. You can actually see there was a tranche of funding that was for designated public hospitals. These are county and UC hospitals.
Mhm.
But the One Big Beautiful Bill Act has many other provisions in it that I would imagine have impacts to counties. There are, like you can imagine, one of the big ones would be community engagement requirements that requires people that stay eligible, able-bodied adults to basically work a certain amount of hours to stay eligible for Medi-Cal. If that results in disenrollment for Medi-Cal, then it sort of creates a question about where do these people access coverage. Prior to the Affordable Care Act, counties were a major source of that. So does this shift some of the responsibility back onto counties? It raises complex questions about the state and county relationship. Counties also implement eligibility rules, and so counties, likely would have to revisit their sort of there likely would be administrative costs to implement a lot of the measures. So in that sense, I could imagine there being some volatility to counties from that.
Mhm. Yeah. Yeah, I mean, that's one of the things that we've been looking at in our county level snapshots is, based on all the available information directionally, what do we think the impact will be of all of these specific policy changes, but also cumulatively on populations and hospitals and even the economy. So we'll be publishing that in the next couple of weeks as well, and we will share that out with the group for more information. Other questions? I think we've answered all of the questions from the group.
I thought I saw one that raised a technical question about, doesn't the state pay for?
Yeah, it looks like there's a question in the chat here. It says, doesn't the state pay a portion of Medi-Cal? How does it work that only the federal government pays the tax?
Yeah, so that's where it gets complicated. I glossed over it, but if you want the full answer, the MCO tax really raises more like $14 billion in gross money. And then when the state pays health plans back for that, the state share comes from a portion of the MCO tax money and then the rest from the federal government. And so that nets out to about 7.5 billion. So that's the more complicated answer. But that's really complicated. So I try to gloss over that and just focus on the bottom line when I talk about it.
Mm-hmm. You mentioned that this tax, has been referred to as a loophole. And I'm curious, how do you respond to that characterization?
Well, I would say that, the state, did operate within the rules that they existed at the time. The structure of the tax has,
Mhm.
it's not new. It's existed for maybe a little less than 10 years and had been approved by different federal administrations.
Mhm.
This isn't the first time the administration has raised concerns about this. The Trump administration in its first term, proposed a series of rules that also would have included some of this now adopted language. Those rules
Mhm.
were ultimately rescinded. So this has been, I guess what I would say generally is healthcare related taxes are kind of a good example of, federal and state relations with each other. The federal government has an interest in, protecting its sort of costs. States have an interest in trying to fund their Medicaid programs, which are quite costly. They're among the biggest parts of their budgets, and finding ways to support that. And then, states also are represented in Congress. And so Congress also has an interest to ensure that states are supporting their Medicaid programs and are doing so in a way that's financially viable for them. And so that's how these healthcare related taxes sort of came about. And that's part of the discussion that states have with the federal government. What should be the rules and what is the right mix? So, these are things, state didn't do anything secret, that it structured this tax. It's also not the only, we're not the only state that structured our tax this way. Several other states do this too. And,
Mhm.
it's something that the state did with approval from the federal government, and the federal government also has the ability to change the rules over time. And that's sort of what happens. So, I guess that's sort of my view of it. Is it's just part of the regular sort of back and forth, relations that the federal government and the state have with each other.
Mhm. That makes sense. Thank you for that. A couple more questions have come in. Would it be possible for the legislature to approve much larger MCO taxes on all health plans?
Well, we currently charge a tax on all of the, which you call the full service health plans. So we don't tax like specialized dental or vision plans. I'm not sure we could.
Mhm.
I'm not sure about the federal rules on that. We also do not charge health plan enrollment in the Medicare program, and that's also something that ends up benefiting the federal government. I'm not sure we
Mhm.
could do that either. So I'm not sure it's a matter of increasing the scope of who is taxed. It would be more about the tax rates themselves. Should we have a larger tax on commercial enrollment? And again,
Mhm.
the policy difference there is, instead of drawing down more federal funding, the cost would shift onto consumers of private health insurance. And they would be that would be supporting the cost of the Medi-Cal program, which they're not enrolled in. So
Mhm.
that would sort of be the policy consideration for the state.
Mhm. And then another question, admittedly not totally related to Proposition 35 and the MCO tax, but um, any updates you can provide on changes to Medi-Cal waivers?
Yeah, I don't have a ton of information right now on that.
Mhm.
We do have some waivers that are set to expire over the next few years, including our major CalAIM waiver. So I have heard some discussions around, what does that mean in terms of getting them renewed or not. But I don't have a lot of information to share. There's also been some recent federal guidance around there's been sort of a changing federal view about waivers involving, like, I guess what we call in California community supports.
Mhm.
So, but I'm not aware of any, I don't have a lot of information yet about where our waivers now kind of stand with all of that. I would imagine they would probably be bigger issues once the waivers come up for renewal, but you know, it's just hard to predict. The landscape sort of keeps changing here.
Yeah, yeah, I hear you. All right. Well, thank you so much. We really appreciate you sharing all of this really helpful information. I'm gonna give a sneak preview of our next webinar. topic. And so let me just share my screen here. So our next webinar is next Thursday. It's the third and final webinar in our webinar series, and we are titling it "What Counties Know: Local Perspectives on Medi-Cal Policy Changes." And will be a research showcase based on insights from our county's RISE project. And so we have been interviewing dozens of county level health administrators to get an idea of what are some of the impacts that are already being felt at the county level and their insights on some potential strategies moving forward. So we look forward to seeing you all next Thursday. And thank you again, Jason. We really appreciate you being here today. And hope everyone has a great rest of your day. Take care. Bye-bye.